see me from there?
Yes, yes, you can. Yes.
Thank you very much for coming. As Director of the Wellcome Centre and co-director with Felicity Thomas of the WHO Collaborating Centre, it's a pleasure to welcome you to the first Culture and Health webinar and also the launch of our policy brief on antibiotic resistance, focusing on the cultural contexts. Just to say a few brief words about the series first, if we can have the next slide, Anne.
I'm trying.
The webinar series overall this year will have 9 webinars over 2019, examining really timely, relevant, pertinent issues around the broad theme of culture and health. But the central aim is to create knowledge and disseminate knowledge that has an impact and is of value to health policy makers. This one is focusing on ABR, the next one focuses on the cultural context of air pollution, and upcoming webinars look at death, transgender rights and smallpox eradication. And the website...
It's not responding.
The website for that will come up in a moment. So if you want to find out about forthcoming seminars, the website, you can go to the website and see the full webinar calendar. All of our webinars are live streamed, and if you join, you can ask questions through Slido, and I'll say something about that just at the end. The sort of format of these is that we draw together an interdisciplinary panel of researchers in the humanities, often scientists, policymakers, and practitioners as well. And we bring them together to think through how we can address global health challenges. So although we're thinking through the conceptual, the methodological ways of bringing scholars together, we have a very clear end point, and that is shaping policy in critical ways. And this is part of course, the focus of the ABR work. And it's important to say that the series is a collaboration between the Evidence for Health and Wellbeing in Context, which is, we have some people from the WHO, Niels, Andrea, Priya, and Saskia, you'll be hearing from in a moment. So it's a collaboration between people at WHO Europe, in particular in Niels's group, the WHO collaborating centres at the Universities of York and Exeter, and it is, and we're very grateful to the Wellcome Trust, it's supported by the Wellcome Trust as well. Today we look at, you having any luck?
No, I keep trying.
Today we're focusing on our ABR policy brief. And the aim of this, the purpose of this, was to think through, or beyond technological solutions to the challenges of antibiotic resistance, to think about the way in which cultural contexts shape the prescription and use of antibiotics, the transmission of antibiotic resistance, but also the ways in which culture shapes the regulatory and the research environment. And in a moment, Katie, as the principal author, will be talking through the overview of the policy brief. There is the website for the future seminars. This is the second policy brief. The first one we think was a very forceful statement about why culture matters, written by David Napier and others, making the case that culture is important. What we moved on from there is to identify certain key topics where we could demonstrate the value of research in the humanities and social sciences to understanding and addressing global health challenges. And again, the focus of the policy brief is to review some of the latest literature, to review some of the evidence around ABR, but also to produce quite discrete advice, focused advice for policymakers and practitioners working in the field dealing with the problems of ABR. The policy brief, a draft version, is on your tables. Please feel free to take them away. The final version will be published online today, and a glossier version, this is a pre-glossy, pre-publication version, a glossier version will be produced soon. So take them, but also hand them out, show people. We want this, our research, to reach as many people as possible. Today I'm delighted to introduce 3 speakers. Dr. Katie Ledingham, who is a research associate in the Wellcome Centre and the WHO Collaborating Centre, is now working on an ESRC funded project on ABR, and will be giving an overview as the leading author of the policy brief, give an overview of the brief. Dr. Saskia Nahrgang, technical officer on AMR at WHO Regional Office for Europe has been really key to challenging us in the ways that we express and develop this. And finally, but by no means least, Professor Neil Gow, our DVC for Research and Impact, but in this context, a Professor of Microbiology, with a particular interest in fungal diseases. So we have a wonderful panel of speakers. I want to welcome our online audience who are encouraged to take part in this session and ask questions. In order to do that, you go to the website, if you can see it, www.sli.do, search for the hashtag WHOCH and type in your questions, and Priya is going to collate those questions and pass them on. Before we start, I also just want to say that there are evaluation forms on the desk, I believe, and we would like you, no, we will not let you go until you have filled one in. Maybe Janice and Neil will let you off because I know you have to go early, but please do fill them in because it's really important to us that we get feedback about the value of these seminars in relation to our the purpose. So I'm going to introduce first Dr. Katie Ledingham, who did a fantastic amount of work on this, drawing together the case studies, drawing together and drafting the document, and we gave her a pretty tough time. The brief changed, our views changed, we reshaped and refashioned, and Katie was the person responsible for doing all that work. So, Katie.
So antibiotic resistance is one of the most critical global health challenges facing society today. So far, most attempts to tackling antibiotic resistance have mainly focused on scientific and technological responses. For example, we can see this through increasing international calls for the detection and the monitoring of resistant strains of bacteria using the latest microbial sampling techniques. The WHO Cultural Context of Health policy brief complements and extends these efforts further by recasting antibiotic resistance not simply as a biological and a technical issue, but also as a social and cultural issue that demands a social response. The policy brief is split into 3 sections, with each section examining the impact of social and cultural dynamics on, firstly, antibiotic use, secondly, the transmission of antibiotic-resistant bacteria and antibiotic-resistant genes, and thirdly, on the types of antibiotic research and innovation that are currently taking place. Throughout the report, we draw on case study materials, which enables the policy brief to really demonstrate the value and the importance of a cultural context of health approach. To provide you with an example from the first section of the report, which focuses on antibiotic use, it's known that hospitals are a critical site of antibiotic consumption. It's also known that in spite of the implementation of best practice stewardship schemes, antibiotic use in these settings remains too high. Up to 50% of use in hospital environments is regarded as falling below best practice standards. The case studies that we draw on in the report, and which are based on extensive qualitative research with junior doctors and hospital practitioners, found that this can be attributed to the social and the cultural norms of working that underpin hospital environments. For example, the perceived ideal of learning to become an independent doctor and the strong social hierarchies that exist between junior doctors and senior consultants were found to result in junior doctors relying on broad spectrum antibiotics rather than consulting with their seniors on what type of antibiotic to prescribe or whether or not to prescribe at all. What this example and other examples in the report demonstrates is that instead of simply imposing top-down external targets or metrics to reduce antibiotic use in hospital environments, approaches to tackling this contemporary health challenge necessitate involving those facing the challenge in co-designing solutions to tackling it. So what this might mean in practice is that together it becomes possible to co-construct mechanisms that actually might enable antibiotic decision-making as a key area where junior doctors might feel able to consult with their seniors on antibiotic prescribing. The next section of the report focuses on the social and cultural dynamics of the transmission of antibiotic-resistant bacteria and antibiotic-resistant genes. Transmission can occur through a variety of different pathways. For example, antibiotic-resistant bacteria can be passed from livestock to humans through the consumption of meat, and antibiotic residues are routinely released into the environment through pharmaceutical as well as domestic and clinical waste streams. The report examines not only how cultural dynamics can create new transmission pathways, but also how culture can be a powerful enabler of health and driver of change. So, for example, supply chain actors such as retailers, processors and restaurant chains can be particularly effective in specifying methods of disease management on farms. Understanding and illustrating how these actors drive change is an important part of understanding how cultural pressures can generate better health outcomes. Finally, the third section of the brief looks at antibiotic research and innovation environments. One of the case studies that we draw on in this section of the report focuses on the mantra to treat hard and to treat long. This is a mantra that's associated with the work of the physician Paul Ehrlich in the early 1900s, who believed that the best way to treat an infection was to eradicate the causative organism through a long and powerful course of treatment. The treat hard, treat long mantra has now been contested for some years, with research finding that antibiotic treatments which last for 2, 3, 5 and 10 days can be equally effective for certain infections under certain conditions. But what's particularly interesting about this example is that Ehrlich's earlier understanding of infection became embedded and naturalised within early clinical trial practices where new antibiotics had to be compared to the efficacy of older antibiotics. And the efficacy of older antibiotics was based on criteria that resulted in longer lasting treatment regimes. So this example, which is unpacked in greater detail in the reports, is important because often we don't think that culture, or the social even, exists within scientific and technical guidelines. What this example demonstrates is that culture cannot be reduced to individual behaviours, but also appears in places where we expect it the least. To conclude, the cultural context of health policy brief demonstrates that scholarship within the humanities and the social sciences, with its focus on participatory research and the generation and analysis of qualitative evidence, can effectively complement and enhance scientific, technological and regulatory approaches to this contemporary health challenge. The brief also illustrates how cultural dynamics can enable health and provide new levers for change. It's only by recasting ABR as a social and cultural as well as technical and biological issue that we can open up new strategies for tackling and approaching the contemporary challenge that is antibiotic resistance.
Thank you very much, Katie. One of the things that we experienced as we developed the report is the difficulty of finding those case studies around culture, cultural practice, society pressures, and antibiotic use and resistance. And one of the things that Katie did for us was to trawl through a massive literature to identify those case studies. And it's really important for us that our work covers the European region in particular, but also more globally as well. And thinking about the European region, it's a delight to welcome Saskia Nahrgang to speak.
There are lots of things to worry about. According to an advertorial I read on my way here entitled, "Please personalize your marketing message," Norwegian businesses are worried about the arrival of Amazon.com in the country. And with good reason. Many might find themselves out of business because, according to the article, they failed to make an effort to get to know their customers when they had the chance, giving Amazon, the big data powerhouse, a comparative advantage in Norway. The story from the business world stuck with me when I thought about AMR and cultural contexts of health. Like in any other business, the business of bringing better health to the people requires that we, the messengers, understand the recipients of our efforts, their needs, their expectations, their preferences, their life contexts. It also requires that we acknowledge their need for participation. The good news for Norway and other Northern European settings is they need not worry too bad and too much about AMR because they belong to a group of settings that are doing comparatively well. They have universal health coverage in place, they manage to preserve older antibiotics, they benefit from stable conditions in animal husbandry, they have sophisticated surveillance systems in place, and comparatively low rates of antibiotic resistance and use as a consequence. Other global and European settings are not so fortunate. A recent ECDC study published in the Lancet Infectious Disease Journal showed that an estimated 33,000 people in Europe die from infections that were resistant to antibiotics in 2015. A recent report published by the OECD states that Southern Europe risks by being particularly affected. Italy, Greece, and Portugal are forecast to the top of the list of OECD countries with the highest mortality rates from AMR. Beyond OECD countries, data are less complete, but the situation is equally worrying. AMR has been compared to another global challenge, climate change. Like climate change, AMR is innately complex. AMR has been called a policymaker's nightmare. Why? Because it is full of contradictions. We are calling for private and public investment for new drug development. We want and need to use antibiotics both in animal husbandries and human healthcare, but at the same time, we want to discourage and limit their use as much as possible. At the same time, AMR requires us to collaborate and coordinate across multiple sectors, disciplines, and often in the absence of easy and established ways of collaboration. On top of it, we are confronted with the moral dilemma of balancing immediate individual health benefits against collective future health gains. The good news is the momentum and the political appetite to tackle AMR has only continued to grow in recent years. This has come with tremendous opportunity for learning and for expanding the tools at our disposal. WHO is forging important connections across areas, programs, and disciplines, which eventually will allow us to integrate and mainstream AMR. The brief on cultural context of health to address AMR is a great example for this integration. I would like to mention one more number, 43. Human cells make up only 43% of the body's total cell count. The rest are microbes. Understanding this hidden half of ourselves, our microbiome, is rapidly transforming understanding of diseases from allergy to Parkinson's. This different perspective on microbes calls into question whether using polarizing language about good drugs and bad bugs, superbugs, is achieving the results we want. Language taps into emotions, and emotions, not just facts, drive decision-making. Like the Norwegian business in my example, that are threatened by Amazon, we need to better understand our clientele to stay relevant. Otherwise, we're not doing a good enough job. Our solutions need to be as rich as the problems we're trying to tackle are complex. It means that we need to deal with complexity by embracing it and by adopting a cultural context approach. The policy brief does not propose any quick solutions. It does something more important. It takes a step back and takes a fresh look at an issue that has been around since the very invention of antibiotics. It underlines that science and technology alone, as cookie-cutter solutions, are not enough. We learn that culture is more than a barrier to achieving desirable healthy behaviors. We are very fortunate that more and more areas are realizing the potential of integrating AMR in their work. It will hopefully allow us to design better, more inclusive, and more effective interventions in future. Thank you.
Thank you very much, Saskia. One of the pleasures of working with the WHO has been that as scholars in the humanities and social sciences, we are very good at talking to each other and not sometimes moving beyond our own disciplines or our own collections to speak with policymakers and scientists. And it's fantastic that Saskia engaged with the report from the start, provided fantastic feedback from a very different perspective to us. And that's crucial to producing these kinds of reports. It's not academic research, policy, practice, whatever. It's about co-creating, co-researching the challenges and co-creating the solutions. And in the spirit of that, it's fantastic to introduce Neil, who is a scientist working in these areas as well, for the final talk. Thank you, Neil.
Well, thank you very much, and good afternoon. Yes, my name is Neil Gow, and I'm the Deputy Vice-Chancellor for Research and Impact at the University of Exeter. So first, thank you for the invitation to be here to celebrate this launch of the WHO report, Antibiotic Resistance Using a Cultural Context of Health Approach. That's the critical thing to address a global health challenge. And can I just add my congratulations to Katie and her co-authors, Steve Hinchcliffe, Mark Jackson, Felicity Thomas, and Goran Thompson, as well as all of those contributors and collaborators who co-created this. So, as you've heard, I'm a microbiologist, and in fact, until December 31st, I had the honour of being the president of the Microworld Society in the UK, and the first president of that society was Alexander Fleming. And so you won't be surprised to understand that I don't need to be readily convinced that antimicrobial resistance is one of the world's grand challenges. But Fleming himself discovered penicillin in 1928, right? So, and it was first produced on a mass scale and distributed in 1945. Now, during that time, it's difficult to get exact numbers, but the estimates is that penicillin alone, as one of the antibiotics, has saved something in the region of 80 to 200 million lives. And pretty sobering to realise, as it's pointed out in this report, that it's predicted that by 2050 there might be as many as 10 million people annually dying of infections due to antimicrobial resistance. In other words, infections which we'd otherwise would be able to treat in the past. Now, in context, that's more than the sum of all the cancers that were reported in 2016, 8.9 million people. This is a huge, huge problem. And I think for many people it's quite difficult for them to imagine being plunged back into a sort of pre-Victorian era where simple treatable infections are now deadly infections, cuts, things which we recognise now as being completely unthreatening. Now, as Katie mentioned, for microbiologists like me, it's tempting to think about how we deal with that challenge by going to the science base and going to the lab and working out the mechanisms of resistance and about how antibiotics are detoxified or they're thrown out of the cell by efflux mechanisms, or their targets are mutated so they're no longer sensitive to the drug. Or in terms of getting new antibiotics to deal with the fact that other ones are becoming redundant. Or better stewardship, so we manage them for longer periods before we get resistance. But the thing that this report points out is that all of that knowledge is pretty impotent unless you've got this holistic approach which incorporates our understanding of the social, the commercial, the cultural drivers of how medicines are prescribed and how they're used, and the influence of all those factors on the development and the evolution of drug resistance. And as the report points out, that many countries antibiotic use is essentially unregulated. And frontline and immensely precious antimicrobials are often available over the counter, and sometimes they're used in agricultural practice. So culturally it's often difficult to understand the concept of antimicrobial resistance and how our health is not just threatened, but as Saskia pointed out, it's also simultaneously promoted by our life with the microbes that are living with us. So this is a challenging concept to get over. So the bottom line is there's no real effective inroads that we're going to be able to make into AMR without a sort of concerted approach. And it's got to recognise the cultural, the social, the economic dynamics alongside the clinical and the biological aspects of AMR. So this report is really critical because it draws together that information from a huge range of sources, and it's a synthesis under this whole of society, one health approach, and that's underlined by the WHO's Global Action Plan for Antimicrobial Resistance. So I just want to say congratulations to all of those who've been involved in this study. We're very proud at Exeter to be so intimately involved in it. And I'm looking forward to hearing more about this. And it's going to remain, of course, as one of the real global grand challenges of the world in terms of human health in the next 50, 100 years. Thank you.
Thank you very much, Neil. I would say it was one of the fears we have sometimes when we are, as scholars in the arts, humanities, social sciences, and quite a fear that when we bring up these questions amongst policymakers and scientists, we have a fear that they might not be receptive. What is interesting about this report, in some ways of doing the report, is how we were often pushing against open doors, that some of the arguments we were making were already part of the discussion within the science communities and the policy communities. The key challenge for us, I think, was finding that evidence, and this is a key part of the report, that then allows scientists and policymakers to act and work in different ways. And that's an ongoing challenge in much of what we do, not just in the work on ABR, but in most of what we are doing in cultural contexts of health work. We have now time for discussion. I'm going to give some priority to the online people at the moment. Can I just, have you got some questions, Priya? And could I just remind those online that there is also an evaluation form that you can fill in online. We won't let you go until you've done it, but please do fill that in. We then have 30 or 40 minutes, and thank you very much for the speakers for being concise. That's really neatly done. Thank you very much. So we have some time. I'm going to invite the online viewers first, participants first, and then we can have a more general discussion in the room. For those of you who can stay after tea and cake, we will then have an informal session as well for 30 or 40 minutes after tea, when we can think through not just the ABR challenge, but how we incorporate cultural context of health approach into more of our work on health and well-being. Niels, or...
Yeah, so we have a few questions online. Also, maybe just to online audiences, you can use the Slido app on your phone. So just type into your browser slido.com and then enter the hashtag WHOCH, and that should put you through to the question page, whether you're using your phone or the computer.
Do you want the speakers to be somewhere, Niels?
Yeah, I guess it might be a good idea for the speakers to
return the camera there.
Yeah.
Thank you.
That's the plan.
Have a seat
Saskia,
on the
Kate, Neil,
chairs.
you've got 10 minutes. Thank you.
So I think one of the perhaps most interesting questions is why can't we just invent new antibiotics? What's the problem? Why have this cultural context of health approach? All we really need to do is replenish the pipeline.
So maybe I'll add a few things. I wish it were so simple as one part of the answer, and even if we did, it would only be stalling the inevitable that we have to do, which is to address things more holistically. So to make an antibiotic pipeline is drying up fast. A lot of companies have spent a lot of time doing this, and there's been huge amounts of money poured into that process. And yet the numbers of new generation antibiotics which are coming out are very rare. Most of them are modifications of existing drugs, and modifications of existing drugs give you similar profiles, so you often get resistance emerging to a whole suite of drugs. It's not entirely a gloomy situation, but it's an expensive business, and many companies are actually not very engaged with this process. Their focus is on more chronic diseases, which frankly get them more money. You have to be able to make about $1 billion US a year for a number of years while you hold the patent for that to be successful, and that actually is not a lot of money for some of the big international pharmaceutical companies. So actually antibiotics are on the borderline of sort of being financially viable, and often they're used in parts of the world and needed in parts of the world where people can ill afford to use them. So there's lots of constraints on that pipeline. There's been a lot of work there, a lot of very important academic work, but it's not really a solution to the problem that we see.
I can add to that. I mentioned controversies, and this is one of these controversies that on the one hand, of course, we are trying to make investments possible to develop new antibiotics, but really the new classes of drugs that shall be developed in future should be reserve antibiotics beyond the third line of treatment, fourth line treatments, and we don't really want them to be used broadly because they need to be available for cases that have failed to be successfully treated with the first and second line and third line choices that are currently available. So it's really not a question of either or. I mean, we need new drugs, but it's not a solution in the long run if we are continuing to behave the way with these medicines as we have.
Can I just add something from the historical dimension? I think those points are absolutely right, and I think that historically antibiotic resistance follows very rapidly on antibiotic production and use. And so unless there's a more systematic, generic approach to this, then the production of new drugs will create, yes, it will address some problems, but it will create resistance problems as well.
I have a question also from an online question, which I think Mark and Katie are going to be particularly happy about. Why did we choose to focus the report on antibiotic resistance and not antimicrobial resistance?
Katie?
That's a really good question. So we decided to focus on antibiotic resistance, partly in terms of coherence for the piece. Antimicrobial resistance is a wider issue, and it entangles other diverse issues, so it just provided a narrow lens to really unpack why a cultural context of health approach matters, and how it can be used to address a key health challenge like antibiotic resistance. But of course, a number of the sensitivities that we developed in the brief will also be relevant to antimicrobial resistance.
Yeah, it's a really interesting question. It's a question that we talked about through the process. If you think about the label antibiotic, of course, it's historically specific in many ways, that the early drugs and compounds used to treat infections were antibiotics. And as developments happened in the technological field, then the term antibiotic was broadened to antibacterial and antimicrobial. So in some ways, antibiotic, you could say, is a historical term that might not be quite appropriate. On the other hand, antibiotic resistance is something that's much more familiar to most people. And if we do, one of the things we did in the search, the literature search, is that antibiotic resistance came up much more often than antibacterial or antimicrobial. And again, in terms of the language of policymakers and practitioners, antibiotic resistance is much better known. And it's an example in a sense, as a historian, I would say I prefer antibacterial or antimicrobial as broader, more inclusive terms. But if we're going to speak with policy audiences and practitioners, then we also have to be sensitive to the kind of language to which they will be receptive. So there's a balance, in a sense, between the historical and cultural specificity that we want to get across, but the need also to work with the language with which policymakers and practitioners are familiar.
I feel it's duty bound just to throw in a couple of comments as somebody who works on medically relevant fungi, which people know much less about, but nonetheless are estimated to account for about 1.5 million deaths a year now in total. So there are drug-resistant organisms which are not bacteria, not just fungi, but parasites and viruses, and these are also highly problematic. And in the fungal world, this is another thing which is rapidly racing to the front of our attention, and there's barely a community to deal with it. And there's a very important cultural context. So, for example, the driver of a lot of antifungal resistance to aspergillus, which is predominantly a lung infection, seems to be coming from agriculture and the use of fungicides in the field, generating resistant strains of organisms which then end up in the lungs of patients in hospitals. It's a really important problem which comes right outside the clinic for its origin. And there are new organisms emerging all the time. There's a new fungus called Candida auris, which people are extremely concerned about because it's a multi-drug resistant fungus, just like it exists for bacteria, and which is unrecognized until 2009. Nobody had ever seen it before, and now it's in all continents of the world and is a major concern in clinical situations. So we can learn some general principles from this report and from this type of work, which can be applied in other settings, and there are multiple settings in which we should apply it.
Thank you. There's also a question here about the cultural context approach and whether it conflicts with conventional health policy. And if so, how can WHO as an agenda-setting and medically dominated body ensure inclusiveness? So this, the challenge of having a kind of cultural context of health approach within the setting of WHO, does that create kind of particular conflicts, as it were?
Sounds good.
I think that's a question for Niels.
I know, I'm desperate to answer it, but...
I can say something. I think it's a key challenge for us, is that WHO, at least in some areas, likes the sense of a common policy framework. Something that can be applied, or at least used to model policy responses. And what we're arguing goes against that in some ways, because we're arguing for cultural specificity, for recognizing cultural specificity within a common policy framework. I think the value of this approach is not so much in undermining or undercutting that the aim of developing a common policy framework. It's suggesting a way of thinking through the ways in which social and cultural factors impact, and suggesting to policymakers places where they could go to find case studies, people they could ask, ways of working that allow the implementation of the culturally sensitive implementation of that common policy framework. So there is a tension there, yes. What we're in some ways suggesting is a method, an approach, that allows us to reconcile those tense relationships between common policies and culturally specific policies.
I mean, I might just push you a little bit, Saskia. I think part of the question that's meant here is about whether or not WHO colleagues, people within WHO, feel culture is simply not part of their job. So it shouldn't be something they need to worry about. And that, I think that perception is perhaps, it's perhaps a little bit of a block perception of how WHO operates. Perhaps you can say something about the kind of realities of your job, as it were, which is in many ways highly cultural.
Well, I think you might have a point there, but at the same time, I think we're evolving quite a bit from that. I think most colleagues working for disease-specific programs are not so happy about being confined to their silos anymore, because there's clearly so many constraints because of it. And I think AMR is a program that really exemplifies. I'm not the first program that exemplifies it, but one program that recently has exemplified how important it is to work beyond the boundaries of the program, and as I said, really forge these partnerships and connections, and to acknowledge the role of cultural context, because we see that actually the issue of designing interventions, as WHO wants to do, that are commonly applicable for everybody, that specifically for us in the European office, that doesn't usually work so well, because we have a different clientele, so to speak. So we have, on the one hand, a lot of countries that are leading in the field of AMR, and on the other hand, we have countries that are lagging behind. So within the region for Europe, we have different groups that need different types of technological but also cultural approaches. So I think we have, in our setting, really exemplified that we can do that. But I think globally it's still quite a problem, and is not helped by the types of structures that we're forced to work in as it is.
Another question from it's a rare occasion where we have a name. Most of the posts are anonymous, but this is from Michael from the British Society of Antimicrobial Chemotherapy. And he was wondering, how can we create the mechanisms by which successful interventions in one cultural context can be adopted and adapted by another? So I think this is a tension that we get quite frequently, where the assumption may be, okay, we're developing something that has a cultural context, but does that scan into a different cultural context? Is it really as simple as saying, okay, this works here, it will work somewhere else?
No.
I agree.
I think it's a real challenge for the ways in which we work in looking at cultural contexts, is that sense of whether you can translate and whether you can scale up. And the answer, of course, must be in a sense no, because we're talking about cultural specificity here. And again, what we're suggesting, I think the focus on culture is not to say that this culture, tending to culture in this way here, works here, but that if we work together to understand the cultural context in a specific location and give people the tools to do that within that location, then that will open up new pathways, new ways of working that will address these challenges. So again, it's not so much, we have to recognize that culture is multiple and multifaceted, and that will be different in every place. What we're suggesting is that not taking into account culture in any location is to miss an opportunity to address health challenges.
I was struck once. I had the pleasure of introducing an award lecture at the Microworld Society, which was given by Dr. Stephen Baker, who works at Oxford but spends most of his time working in Vietnam on antimicrobial resistance, among other things. And he pointed out that, well, if you want to change something in the UK, perhaps your primary target are healthcare practitioners who will be the pinch point at which you change that culture, you'll get an effect. But if you go to Vietnam, there are actually very few doctors, but there are even more pharmacists and chemists. You know, they are dotted around every corner of every major city, and people essentially self-medicate. And so you cannot use the same intervention, you do not have the same mechanism of control or implementation of a new idea. And there's evidence, for example, that the treatment, one of the most common treatments is the treatment of diarrhea. And for most simple forms of diarrhea, that Stephen was pointing out, the evidence was that a course of antibiotics did not improve the outcome by much at all. There was very little need to do it, but everybody did it because that was the level of their understanding of what you could do as a concerned parent, for example, with a child or somebody in your family who had a dose of diarrhea. So these require radically different understandings of how culture works and how drugs are, how available drugs are, and you can see that concept is radically different, completely different solution is required.
If you're designing any health interventions at the drawing board, it's always based on assumptions. And I think what this seminar or this brief teaches us is really that we have to challenge all those assumptions and be a bit more specific about what we're talking about. I'm getting really tired of reading these papers about the Dutch model or this and that model of dealing with AMR, because these models, first of all, I think it's wrong to kind of talk about country models, because within countries there's different groups and cultural contexts. So for example, the Netherlands, which is one of the leading examples for how to deal with AMR well in the human sector, they've been doing not so well in the animal health sector for once. And there's also the Dutch Bible Belt, which is not doing so great either. when it comes to dealing well with medicines and vaccinations and so on. So I think it's simply a simplification and a pragmatic approach, which has its reasons, but it's not where I think the future is.
Could I just say, well, looking at the report, the policy brief, just reminding myself, I want to encourage everybody to read all of it, but in fact Annex 2 sets out some of the participatory research methods that allow you to drill down into the cultural context and think differently about how we co-produce knowledge and address these kind of problems. So there's a methodological argument here about taking culture seriously, and that Annex 2, I think, sets out the participatory approaches that will help you answer certain questions about ABR, about antibiotic usage, about regulatory cultures.
Yeah, and I just add to that as well that they don't have to be particularly convoluted methods, so it could just be that you have a focus group or a series of interviews, but it's kind of getting at that more qualitative evidence, that kind of social richness as to what culture means in particular organisations and within particular cultural kind of country contexts, that you can use a social science approach to kind of help bring that to the fore and then co-design interventions to help tackle this issue.
Maybe I...
Sorry, I was about to say, should we open it up or...?
No, absolutely.
No,
you're the chair, Mark.
No, that's name only. Do you have a...
We have lots and lots more questions, so...
Should we have one from the floor,
yeah,
and then maybe intersperse them? Any questions that anybody would like to ask here? Yes, please.
Quite aware that Finland and Russia are using phages as last resort, sort of. Are we in Europe? Are we looking at this as an alternative alongside antimicrobial resistance?
There are some studies. I think, is it Romania or Hungary? There are some places where it's used clinically. It's not been widely used clinically. And of course, the thing about microbes is they evolve to threats. And an antibiotic and a phage are both threats to viability, so you can get resistance to phage just as you get resistance to antibiotics. So what it's useful to have is a wide armamentarium of opportunities that work together with an understanding of a cultural context and the delivery of these interventions. And we are rather polarised I think in the UK around the use of pills and intravenous drugs, and there are other approaches which have not really been used. So combinations of using the immune system to tackle the microbe alongside chemical interventions is another area which we probably could do a lot more with in the future. So there are alternatives to the simple pill that you take orally, and we need to do more in all of those areas to make an impact.
Other questions from the room? Yes.
So just one question, because I think, Katie, you mentioned that there are loads of studies these days show that you can use antibiotic for shorter times and less dose or whatever that is.
Yeah.
But why don't we see, as prescribers, we don't see that reflected in NICE guidelines or any guidelines? We've been hearing this one for a long time, that you can use, for example, amoxicillin for even 1 day, 2 days. But that's not what in the formulas or in the guidelines, clinical guidelines mentioned at all. They're still as they are. Sorry, the other question is that about repurposing the old antibiotics. Is there anything, do you know anything about research in this area? Like using the old antibiotics and repurposing those ones?
Yes, I think one of the things that we look at in the section on research and innovation environments is how when antibiotics were first being innovated, there was this belief that antibiotics would be a miracle cure, and there was a shift away from focusing on the development of new classes of antibiotics. So work instead was looking at antibiotic analogues, which is less regulatory, it has less regulatory hurdles, and also is less expensive in terms of going through the clinical trial process. And Yeah, so I think the kind of structures of innovation that we have really influence the kind of current types of drugs that we have at the moment. And one of the examples that we talk about in the report is how there is a lot of infrastructural and technical skill in terms of finding new antibiotic classes. But yeah, all of these questions are, and the question about the dose duration as well, they're fundamentally imbued with social and cultural understandings that have become sedimented over time and a kind of integral part of clinical guidelines. So what we're trying to do is open that up to kind of wide scrutiny and think, well, you know, how could we do this differently? And if we're going to tackle ABR, how do we kind of shed light on some of the technical guidelines that previously hadn't been opened up to social scientific inquiry?
Okay.
And if I can add to that, I mean, reusing or reintroducing old antibiotics is actually one of the key areas, because we have realized that the antibiotic pipeline is not very promising. There's very few new drug classes under development. Development is very expensive, so one of the first responses really was to look into the ability to reintroduce older antibiotics. There are a couple of countries that have done so very successfully because they never really stopped using as a first-line treatment penicillin, for example. So Norway is a good example for that. They have really managed to keep that alive, but it's also a bit more complicated than that because many countries around the world don't have access to those drugs anymore. There's no stable supply chain, so it's not really a question of you know, is it something we're trying to do or not? It's also regulatory environments that make it hard to keep that full choice on the menu, simply because it's also financially not viable for many pharmaceutical companies to keep on pushing these old drugs out anymore, which have no patent protection anymore and so on. So they're usually generic drugs, so they're not a big cash cow anymore. So this is a bit complicated. The second question you had was about...
It was about the, for example, clinical guidelines.
The guidelines, duration and dosage.
Yeah.
That I don't agree that we're not taking that into account, because one of the main areas that also WHO is working on right now is antimicrobial stewardship, which really focuses on using the right drug at the right, for the right diagnosis, with the right duration of treatment, and the right dosage. So it's like this 4D approach. And so the new essential medicines list is really focusing on, first of all, giving an overview of drugs that should be grouped into access, watch, and reserve antibiotics. So those that should be widely accessible to everybody, then those that should be more reserved for specific indications, and then those that should be reserved for a last resort sort of treatment. And the new iteration of that essential medicines list, which is a publication that WHO comes out with on a very regular basis, is also going to focus more on dosage requirements and duration and so on. But this always has to be very specific for the infectious syndrome that you're trying to treat. So it's based on expert opinion, systematic review, and so on for each of the conditions that allow you to treat to the shortest duration possible, but with a safety consideration if you're that way pushing someone towards a higher mortality or morbidity possibility by reducing the duration. But you're right, I mean, it has been shown that by shortening treatment regimens, oftentimes you're not risking anything for the individual, and in that case it should be reduced as much as possible.
Niels, do you have another online question?
Yeah, I think I have two more questions that I'd like to put out, and there are plenty more. So maybe this is just a request to anybody online. Do fill in the poll, and if you want us to be in touch with you and potentially try to answer the questions that we haven't been able to answer in this seminar, do put your email into the poll, and we can be in touch and try to answer these questions after the seminar has finished. We'll definitely endeavor to get back to you. But there are two questions which I think really kind of pull together what we've been talking about, and then also looking forward. So one of those is about the question of if the answers, or at least some of the answers, lie within culture, what are the levers for changing culture? And I think the way that that this question can be made perhaps more understandable for WHO audiences is we often talk about behavior change as the kind of main thing that the WHO looks at from the social sciences. Little nudges here, little socially constructed events there that help change our behavior. But what we're really, I guess, what this report really is highlighting is something more systemic. This idea of culture change. So, what are the levers? What are maybe, Katie? There are some kind of examples that you can show from the report where cultural contexts have been taken into account in order to actually affect the change in the kind of small environments where they've been deployed.
Yeah, sure. So an example that springs to mind would be, for example, to go back to the hospital, the work that's looked at antibiotic prescribing in hospitals, which I think is a really nice example. So it really clearly demonstrates why you need to take social and cultural dynamics into account. So we know, for example, that there are these strong social hierarchies and that there's particular cultures of working within the hospital structures, and we know that role modelling, that junior doctors and senior consultants, that role modelling is a big thing. So if you can engage with, recognise the kind of social values that matter to senior people in hospitals, that kind of cultural norm of role modelling can actually really facilitate and help to embed a kind of way of tackling antibiotic resistance that it has resonance, it has meaning within that particular context. And that is how you not only affect change, but you affect change in a way that really kind of embeds it and has kind of entrenched positive outcomes.
I think there are, I'd like to add to Katie's, there's a couple of questions really. The first is that behavioural change is important. The question is that behaviour doesn't happen in a social or cultural vacuum, that there are norms and values and attitudes that determine that behaviour, and the question is, how do we understand those norms, values and attitudes, and then how do we change them? I'm not saying that's easy, this is a long-term process, that's the first thing. The second thing is that the nudge approach is interesting because it still assumes that there's a pipeline. Here is some knowledge produced by some experts and we can apply it in a certain context and behavioural change. And most of the examples show that that doesn't work in exactly the same way that we think here's a technological solution, we pass it on to an ignorant public who then follow our guidelines. And I think what we're arguing here is that changing the cultural norms and values and therefore changing behaviour requires a participatory approach, understanding values and norms and working through with people what those norms and values then imply, both in terms of behaviour and health outcomes. So we're suggesting a way of working that exposes the norms and values in the first instance and working together to shift them in the sense of producing a collective good in some ways.
I agree with what you said, and I can think about a good example from actually what we encounter in the field in hospitals, particularly in Eastern European settings, is that culture of being able to acknowledge mistakes or talk about failure, talk about healthcare-associated infections, somebody doing something wrong, that leading to spread of infection and so on, that's a very difficult subject, which actually leads to many healthcare providers not acknowledging the existence of healthcare-associated infections because there's a punitive environment that doesn't allow talking about that subject. And I think many of the behaviors which we would like to change or see change are linked to that sort of a punitive environment in healthcare.
Thank you very much. I'm going to have to close this section because we are 1 minute to 2. I want to thank our speakers. Our speakers have not only presented from different perspectives, but also I think invested a lot in answering some very pleasant questions, I think, for us. I want to thank you all as well for coming. Fill the evaluation forms in. Online participants, thank you very much for joining us as well. For those in the room, there is refreshments outside, and then we will reconvene for 45 minutes to talk through perhaps some of the more generic challenges of taking culture seriously. And at that point, I will ask Dan O'Connor from the Wellcome Trust and Niels to join the panel with Saskia and Katie to think through both the specific and the general challenges around incorporating research in the arts, humanities and social sciences in terms of health policy. So thank you very much. Thank you. Tea and coffee or something.